Welcome to the UK Dementia and Palliative Care Conference 2025 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. Challenges of pain in dementia, presented by Professor Wilco Achterberg, Professor of Elderly Care at Leiden University Medical Center.
Thank you very much. It's wonderful to be here. It's a wonderful place. My friend Adam Gordon says Devon is heaven, but don't drink the Buckfast wine. Indeed, it is beautiful here. And also very friendly people. This morning at breakfast, I've been called darling and honey for 20 times. So this is wonderful. I think I stay here. So I'm going to talk with you about pain and dementia. I'm from the Leiden University Medical Center, and I'm also a visiting professor in Nottingham. And first I'm going to tell you something about Leiden University, because it's the oldest university in the Netherlands. And it's from 1575, which is exactly 1 year after the city of Leiden withstood the Spanish conquerors for many years. They were very hungry. And Prince William of Orange, you all know him here, he said to this population, I'm very thankful to you and I'll give you a gift. And you can choose a lowering of tax or a university. And I'm very proud that they choose for the university. So 1575 is our university. And it's also a beautiful place with lots of museums. Has everybody ever been in Leiden? Yes, okay. So, am I right? Yes. Okay, so first I want you to stand up, please. Sedentary behavior is not good at all. But also, I would like you to discuss this case for a few minutes with your neighbor in the front or back. So it's Mrs. P, and it's something that I experienced in my care home. When the nurse helps her every morning, she smiles. She enjoys this contact, although she's not verbal. You can only see her smile. And it stops. The smiling stops. And so I would like to have you 1 or 2 minutes to discuss with each other what could be the case here and what should you do now as a start for this. So, thank you. This is great. We can do this all day, I think. It's wonderful to hear you. I will come back to the case at the end. And so, but probably you would think that my talk is about pain, so this has something to do with pain. So, but I want to take you back to the origins of pain. So, what is pain? So, I take this picture, and this very interesting picture, because if you look, there are some persons that express signs of pain. Of course, the person which is hit. But the interesting thing is that I don't think he wants to avoid it. He has his telephone in his hand. He probably makes a video, and this will boost his confidence, will make him socially important. While in the background, you see a person who expresses enormous pain, but he isn't hit. You can see it. He's defensive, etc. And so, and this expresses the complicated things of pain. So there's a lot of things going on in the brain. Yeah? So there's this cortical plasticity, because the brain changes over pain. It's very important what your beliefs are about pain, the circumstances. So all kinds of things happen in the brain. So probably it's very complicated to fully grasp what pain is. But I will try to make it a little bit more simpler. That if you look at pain, there are many issues next to the nociceptive stimulus. Of course, there are all kinds of psychological aspects of pain. So you have past experiences of pain. It may lead to anxiety or depression. There are also, of course, the physical. So you have comorbidity, or like arthritis, etc., or cancer. And then you have the social aspects of pain for your roles in society, and the spiritual aspects of pain. And the meaning of pain, probably you may be connected, especially if you're older, to dying. You may fear the unknown. And so if you look at this concept of pain, it's close to the concept of palliative care. It's the social, physical, spiritual, psychological aspects. It's also these aspects that are very close to the concept of what we do as comprehensive geriatric assessment. So pain is really a geriatric and a palliative concept. And so if I talk about pain, it's not the top of the iceberg that I'm talking about, but it's the part that is below the sea. And that's something that I want to discuss with you in relation to dementia. So, but first, let's look at people with dementia. Usually are older, the pain in the lifespan. And of course, we know that the older you get, the more comorbidities you have, and the larger the amount of pain or the prevalence of pain is higher. But not only the prevalence of pain is higher in the life course, but also the meaning of pain. If you are a baby or a 6-year-old and you fall off your bicycle, your pain means something different than when you are 90 or 50 or a young mother. So we have to acknowledge the fact that pain is not a thing that is fixed. It's dependent on your age. It's also dependent on your function. If we look, for instance, at frailty, and probably you know the concept of frailty, we can also think that frailty is related to pain. And so, of course, this is, I'll skip this slide. Although we are very successful in aging, and probably if we look at 70 years old now, they're probably much more healthier than they were 20 years ago. But we see those patients, and we see them in the nursing home, we see them at home, and these are the patients that probably also have a lot of pain. And we can see this from research, that the frailer you are, the more pain you have. So the pain is related to aging, to comorbidities, to frailty, and to many comorbidities that also leads to disabilities. So pain, and it's in all years. So also when you're at middle age, pain is something that keeps you from working or etc. And one of the things probably you also know that if you are in pain, it tends to have this circle, this chronic pain circle, because if you are in pain, you will be fearful of injury, you will decrease your activity, you will get muscle loss, sarcopenia, flexibility loss. That will lead to an increase in pain. That will lead to probably or sometimes to unwanted thoughts, anxiety, depression, and that's the circle that we will not want. But now I'm going to the pain experience in dementia. So probably you know that pain is such a complex thing that there's a lot of cognitive abilities necessary to interpret it and to not get into this chronic pain cycle. But if we look at these cognitive performance, that is, of course, dependent on your brain function. And we know that in dementia is a disease of the brain. So if we look at the changes in the brain in dementia, dementia, of course, you know, is a container for many diseases. Most prevalent are Alzheimer's and vascular dementia. So at the left, you see the brain, which is this guy, this brain. This is a healthy brain. You can see it's like a cauliflower with the gray stuff on the outside, which are the cells, and the white stuff are the connection between the brain areas. And this is a brain of a person with advanced Alzheimer's disease, And you see especially the gray areas, the cells are gone away, and it looks like this cauliflower has been too long in the refrigerator. This is a CT scan of a person with vascular dementia. And what you see is that the lesions are in the midbrain, are in the connections. So probably if I want to make the connection with you of the changes in the brain in dementia, what it could mean for the changes in the pain system. So Alzheimer's and vascular dementia are different. And so now we're going to the brain as a pain factory. And this pain factory, some pathways that we can distinct. One is the lateral pathway, which is, in the evolutionary sense, a very old pathway. And this pathway is called the sensory discriminative pathway. It tells you, is there pain and where is it? And that's a little bit it. And then in the process of the evolution, we develop this medial pain system. And this medial pain system is more the cognitive, evaluative aspects that I introduced you to. So this medial pain system tells you, what does this mean? So the lateral pain system tells you, is there pain, where is it? And all this cognitive evaluation that you do is from this medial pain system. So this is a complicated graph. This is a graph made by my colleague Erik Scherder, and it's the pain pathway. And so in the right, you see the lateral pain pathway, and you see it's much less complicated than the medial pain system on your left. And it's going up from the toes to the brain, to the outside of the brain. And in the end, you see the S2, that's the somatosensory cortex, and there it's all happening and all coming together. So, but we also know which areas and which cells are affected by, for instance, Alzheimer's disease. So now I'm going to take you to what happens in the Alzheimer brain. So look good at this picture, and I will show you what happens. All the black dots are the neuropathological changes in Alzheimer's disease. So it's a disaster. So what does this mean? First, we look again at the lateral pain system. It's the pain system. Is it pain and where is it? But in the end, you'll see that the end station is intact. So that would mean that people also in the end stage of Alzheimer's disease can sense things. And we know that. We know that because in the end stage, we give patients with dementia something soft in their hands and they like it. They can feel it. But then we look at the medial pain system. So the motivational and the aspects of meaning. At the end, the highest place, there are black dots. And so there are some dots, yes, some cells which are not affected, but in the end, it's affected. So this would mean that a patient with Alzheimer's disease cannot give meaning to pain. Which 20 years ago, 30 years ago, some people say, well, maybe then people with Alzheimer's disease do not suffer from pain. And luckily I see people sitting their head. So this is interesting, yeah. Shortly, also vascular dementia, which is in the different brain areas. What happens with vascular dementia? So again, this is the normal situation, and this happens with vascular dementia. No black dots. No black dots because it's in a different area. It's in the connection area. Do you see differences? Here. The connections are broken connections. And the interesting thing is that we know that, for instance, if you have an amputation, you could have pain in your toe, phantom pain. And we speculate, and we have some studies, I'll show you one, that these kind of deconnections can lead to what we call central pain. So the brain thinks that there is pain, although there is no organ or tissue. So this is vascular dementia. And there are not many studies. We did one study, and we saw indeed that people with vascular dementia have more pain than people with Alzheimer's disease or people without dementia. So that's a different group. Most studies that I will show you now are done with people with Alzheimer's disease. And one of the things that, of course, we should look at is this question: can people with Alzheimer's disease suffer from pain? There are different kinds of studies that you can do, and one of the issues is that self-report of pain is complicated in the end stage of dementia. But you can look at, you can do experimental studies, you can look at brain activation, at pain reflexes, you can look at facial expressions and autonomic responses, and these studies have been done. This is a study from Australia, where they used a functional MRI, so you can see what happens in your brain, what activity is in your brain, and they asked people with Alzheimer's disease and a control group to go into this machine, and they have a pressure electrode on the finger, and they looked at the differences. Interesting study, very complicated, because the people with dementia, they were instructed, then they lay there and they forgot the instructions, and they thought, well, what's on my finger? And then they told them again, and so, but after a few times it happened. And so you can see the results on your left. So the left brains are the control group, and the right brains are the Alzheimer group. So what do you see? There's much more activity in the brain with people with Alzheimer's disease. So this is not something that you would expect if they wouldn't suffer, or suffer, not suffer, but we know that there is a lot going on in the brain. Also, if you look at pain reflexes, the pain reflexes are within the lower threshold in milliamperes. So that's something not that we would hypothesize if there's less suffering. Facial expressions. Also, if you look at facial expressions, we see that people with dementia have much more facial expressions when they have a pain stimulus. The only thing that is less in people with Alzheimer's disease is autonomic responses, like heartbeats per minute or tension, blood pressure. So if we look at these things, the brain activation, the reflexes, the facial expression, they are all much more in people with Alzheimer's disease. So probably it's not a good thing, it's not valid to think that people with dementia do not suffer. Going back to pain, and I told you, pain is also leading to functional impairment, to less mobility. But also, we know that dementia leads to functional impairment. We know that people with dementia can have behavioral disturbances, can have anxiety and depression and falls, but we also know that pain can lead to that. So it's not only a complicated thing in the brain, but also complicated for us as care workers to see if there's changes in the patient, if there's behavioral change, if there's functional impairment. Is it because of dementia or because of pain? It's very complicated, and one of my PhD students have done some work on that. So that's complicated, and the biggest complication is that it's complicated to ask. It is the golden standard in all pain research is self-report. Pain is what the person says what it is. So, and there are all kinds of instruments that we can use: numeric rating scale, visual analog scale, verbal rating scale. We have faces pain scale, and all kinds of combinations. But if you look at these kind of things, you see it's quite abstract, and it's quite difficult for patients with dementia to have this abstract thinking. And indeed, one of our colleagues from Switzerland, Sophie Potet, she did a study in patients with dementia, and most of those patients could not understand these kind of measurements, like the numerical rating scale, the FAS or the Faces Pain Scale. Especially the visual analog scale is very complicated. But of course, luckily, we have other things that we can use to look for pain. And the most important ones are body posture. You can, if you can remember the picture of the bull with the person, you can see all kind of behaviors, all kind of body postures. Of course, facial expressions, but also vocalizations, non-verbal vocalizations. And so we should be trained to look at these kinds of symptoms. It's a little bit too light here, but especially facial expressions are very valid for looking at pain. And so you have specific muscles that contract when you are in pain. So your nose wrinkles, eyelids tighten, your lips tighten, your cheeks are raised, eyebrows, so you can see it. An interesting thing is that the interpretation of facial expressions is something that we are born with. As a baby, you look at your mother's face. It's very important, and we are born with that. Sometimes we tend to lose it, but we are born with it, and it's very important. And you can also look at it in all kind of artwork. And when we had this European group on pain and dementia, and we had a summer school in Amsterdam, we went to the Rijksmuseum. You were there, weren't you, Liz? Yeah, and we looked at all kinds of paintings and the death mask of Michiel de Ruiter, and to see these expressions, because they are from all ages. And of course, these kind of things, facial expressions, the vocalizations and the body postures are used in all kinds of pain scales. And one of the pain scales that's used a lot in the UK is the Abbey pain scale, but there are many more. Many more. And that was also a thing that we as researchers in Europe said, well, that's something that's not by definition good, because there are many scales, but they are not there's not much research done on reliability, validity, and also the implementation is very poor. So in 2011, a group from these European countries came together, and we tried to make what we call a meta tool, a tool that uses the items from all the tools, the best items, and do some rigorous research in it. And we also looked at palliative care, and that's where Liz and I had a lot of work done. Yeah. And so we want to have this PIKE tool, and we want to include the best items, and we also want to use it for several groups and in clinical settings. So, and now I'm going to show you a small introduction video on this scale.
In order to recognize pain in people with dementia, the so-called PIKE scale has been developed. PIKE is an acronym of Pain Assessment in Impaired Cognition. Using the PIKE scale, you'll be able to track indicators of pain in people with dementia in a systematic fashion. The scale has 3 domains. 1. Facial expressions, such as frowning and narrowing of the eyes. 2. Body movements, such as freezing or resisting care. And 3. Vocalizations, such as mumbling
I don't want to. No.
or shouting. Each domain consists of 5 indicators of pain. After you've observed the client attentively, you score each indicator. For example, frowning. If you haven't observed frowning in your client, your score is 0. If you've observed a little bit of frowning, the score is 1. For average frowning, the score is 2. And for heavy frowning, you write down a score of 3. If you, for whatever reason, cannot see the face of the eyebrows of a client, you use the last column. Work your way through the 3 domains. The higher the score, the higher the probability your client is experiencing pain. Not all clients express pain as clearly or in the same way. By observing attentively and writing down the pain indicators systematically within PIKE, you'll be able to recognize pain in people with dementia more easily.
And so the interesting thing is that it's, of course, it was a pan-European action. The scale now is available in 10 languages, also in Chinese and Spanish, etc. And there's a free e-learning. So if you go to the website, pike15.com, you will find a free e-learning. The e-learning is in 3 languages, in English, German and Dutch. And it's a 30-minute e-learning. And what we learned is that it's especially good to do this e-learning with your team. Because what we experienced is that although you do this e-learning, it's very important to discuss with your colleagues the behavior that you see and the interpretation of behavior, and that works very well. Of course, things move on, and observation skills are very helpful for assessing pain. But of course, technology also improves. So one of the things, and Liz also had an article this year in Age and Aging on pain check. And so the pain check uses also facial recognition and the same muscles. And also it includes the Abbey Pain Scale. But it's starting, and the use in clinical practice is not totally, there's no evidence for that it works well, but I think it's very promising. Also very promising is that we can use all other kinds of symptoms. So we, for instance, electrodermal activity. We are doing a study now with people with dementia and intellectual disabilities also, having them a sock with sensors in it and try to measure stress. And especially, in the future, we'll combine that with facial expressions, and we think that we can improve the pain assessment. And that's my last slide. That, of course, we're not sure about the ethical issues, but we did some. We have a PhD student, and she did some interviews with people with dementia, carers, and also professionals. Do you think you would like that in the last phase of life to have kind of monitors? And the interesting thing is that people with dementia, they say, well, I would be fine with that. Professionals find it more complicated, and informal caregivers also, they are a little bit more positive. So lots of, I think in 10 years' time, we will be much further. So back to the case. This was a real case. I took this nurse very serious, and I assessed the patient. And when I opened her mouth, she had a lot of dental problems. So she went to the dentist, and she had some treatments. And a few weeks later, she laughed again while she was. So, 2 lessons for me: always listen to the nurse, and the other thing is always look in the mouth. And the third thing is that, of course, always be aware of pain, also if they cannot express it. Thank you very much.
That's it for this episode of the UK Dementia and Palliative Care Conference 2025 podcast. A huge thank you to our sponsors: Majestic Holidays, Wallens, Amica Care, MC Hearing and Audley, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.